My name is Hahn, and I'm from the Mount Sinai Hospital in New York City, and I want to give a big thank you to KSERS and the moderators today for the time to speak. And today I'll be talking about ergonomics and colorectal minimally invasive surgery, surgeon health and safety. I have no disclosures. And by the end of the presentation, you'll be able to recognize the prevalence and impact of work-related musculoskeletal disorders in minimally invasive surgery and identify key ergonomic risk factors. And I will present evidence-based ergonomic principles to optimize the OR setup and surgeon positioning, and as well as hopefully convince you to implement some practical and easily attainable interventions to help reduce occupational injury. So these disorders are those in which the work environment and performance of work contributes significantly to the condition, and/or the condition is made worse or persists for longer due to the work. And the origin of the definition starts back in the Industrial Revolution, which gave rise to factories. Working in these factories were incredibly dangerous, very monotonous, as you can see, and there were absolutely no safety standards at that time. And here's Charlie Chaplin, 1936, modern times. And before we begin, let's assess the room. In the past 12 months, raise your hand if you've experienced work-related pain or discomfort. For A, frequently, multiple episodes in the past 12 months. B, occasionally, 1 to 2 times last year. Or someone's superhuman and doesn't feel anything. All right. So ergonomics comes from the Greek word ergon, meaning work, and nomos, meaning natural laws and arrangement. The study is concerned with designing and arranging things people use so that the people and things interact most efficiently and safely. And these are the different levels of intervention, starting with personal protective equipment at the bottom, such as the shoes you wear. Administrative controls, which examples are introducing work breaks or overlapping shifts, which are harder to implement in surgery. And engineering controls at the top, where we can really improve by introducing automation or different machines, instruments that can help alleviate or prevent the development of these disorders. And many industries have successfully implemented ergonomic solutions in their facilities as a way to address their workers' risk, but not much has been done for surgeons, and there are relatively few studies and data on surgeon ergonomics. And why is that? Surgeons don't like to be told what to do. Surgical culture prizes resilience under stressful situations. And here in Korea, I'm sure that's 2x the US probably. And surgeons are uniquely pressured to not really report injuries, given that time off means reduced duty and may result in reduced practice or lost revenue. And procedures are demanding. Surgeons are more inclined to ignore discomfort in the OR for the sake of the patient and the procedure. And ergonomics in surgery may be more complex than other disciplines, because the interface is not just between the person and the machine, but then to another person like the patient or your assistants. And many never receive formal education or are even aware that guidelines exist to help prevent these occupational injuries. And across all studies, the prevalence of musculoskeletal disorders and symptoms in laparoscopic surgeons is about 74% on average, up to 90% reporting pain. And even 41% of robotic surgeons frequently report pain, despite being a more ergonomic platform, with the most common sites being the cervical spine and the back at 24%, shoulders at up to 20%, and hands and wrists, frequency of up to 15%. And there's a real impact on surgeon health and career longevity. 1 in 3 injured surgeons take medical leave, modify their practice, or retire prematurely. And these disorders contribute to burnout and workforce shortages. It affects psychomotor performance and potentially patient safety. And there's also the economic burden and the economic burden of all these injuries. And this is not a personal failure. It's a system design problem requiring systematic solutions. And a systematic review and meta-analysis in JAMA Surgery from 2017 looked at almost 6,000 surgeons. Mean age was 46 years, mean of 12.8 years in practice, average of 14.5 hours performing procedures per week. And the most common musculoskeletal diseases were degenerative cervical spine disease, rotator cuff pathology, lumbar spine disease, and carpal tunnel. And over 1997 to 2015, there was an increasing trend of cervical spine disease and lumbar spine disease of 18 and 27% respectively. And of those, 12% required a leave of absence practice modification or restriction, or early retirement. And just last month at SAGES, the SAGES Ergonomic Task Force released their survey results. 43% of surgeons experienced pain most of the time after a typical day of operating, and 22% had already had a work-related injury, with the same complaints, back, neck, upper extremity being the highest. And they were also alarmed at how the adherence to ergonomic best practices among surgeons were so low, despite high rates of work-related pain. 16% of laparoscopic surgeons and only 7% of endoscopists report consistent adherence to these measures. And they alerted the need for improved awareness of ergonomics and targeted training. And there are some modifiable risk factors, such as static posture during prolonged procedures, suboptimal table height, poor monitor positioning, inadequate instrument design, and lack of intraoperative breaks. We operate for hours on end. And there are some non-modifiable factors. Female gender. Female surgeons are 2.34 times at higher odds of pain. Those with smaller hand size, shorter stature, which I fall into both of those categories. And the thing is, increasing patient BMI, which we're seeing, I mean, despite the new GLP-1 agonists, patients are becoming bigger, rounder, and that leads to suboptimal operative table height, heavier organs, heavier mesentery, longer operative times, and that all contributes and adds on to the surgeon burden. And for all the benefits of laparoscopic surgery, there has been an increase in concern on the potential strain of the operating surgeon. The laparoscopic approach introduces unique ergonomic challenges compared to open surgery. In some cases, the OR times may be longer because the surgical field is viewed on the monitor, so surgeons are kind of standing there upright, not really moving as much as you normally would for open surgery. And there's also issues with instrument design. Hand grips are not ergonomic. Instruments are not the same in a size 8 hand versus a 6.5 hand, and the differing shaft lengths are not readily available. And also, laparoscopic instruments require 4 to 6 times more force than open instruments to do the same task. And surgeons surveyed in previous studies were all attendings, but these issues start earlier in training, during residency. So this was a survey that we gave to our own general surgery residency program at Mount Sinai about 7 or 8 years ago. And 100% reported experiencing neck, back, or shoulder pain in the last 12 months. And there's been a recent increase in awareness with more and more committees, societies, creating task force to research and provide guidelines on best ergonomic practices. And regarding laparoscopic surgery, the SAGES ASGE guidelines recommend placing the monitor straight in front of you and keep the upper edge of the display at eye level so your gaze is a little lower than your eye level, and maintain a neutral neck posture vertically, and use multiple monitors. We operate in all quadrants, so use your different monitors to your advantage as we're working around the abdomen. And tuck patient arms, something so simple, so that it doesn't limit restrict your movement to move away where it's more ergonomically more comfortable for you to operate. In terms of table height, use it to benefit you. Adjust so that the instruments remain at elbow height, allow the shoulders to remain in a downward neutral position, flex your elbows between 90 and 120 degrees, and adjust the table height for different parts of the procedure. So if you're doing dissection, you need it tilted this way, or if you're suturing, use it to your advantage. And keep your foot pedal at the same height as the foot. So if you're on a standing stool, the foot pedal should also be on a standing stool. In terms of laparoscopic equipment, avoid instruments with sharp edges and that can dig into your skin. Use locking mechanisms to minimize sustained gripping. And hold instruments in a power grip to minimize finger fatigue whenever possible. And choose powered tools, such as powered staplers, as available. And use the instrument's articulation and rotation to avoid awkward hand and wrist postures, and consider trocar location and modify them as needed. I always alter my trocars than the traditional position because my arms aren't very long. I can't reach across the table as easily as someone who's 6 foot tall with a larger wingspan. And in the US, we say 5s are free. If you really don't struggle for 30 minutes to an hour trying to do something that's very uncomfortable for you and maybe less safe for the procedure, just put an extra 5 in. And then select appropriate instrument handle types for neutral wrist positions, such as pistol grip instruments. And as the robot became more prevalent, there was an analysis of muscle effort and fatigue in the OR between laparoscopic and robotic procedures. This was from SAGES 2018, and they put EMGs of the shoulders and upper extremity muscle groups during lap and robot procedures, and there were similar levels of fatigue between both groups. However, there were different types of muscle groups that were affected. So for laparoscopic surgery, that fatigued the forearm muscles more, while robotic fatigued the shoulder muscles. And another separate study showed that 45% of surgeons experienced strain during robotic surgery, with over 70% reporting neck discomfort. And this was a promotional ad I took from the Da Vinci website. There are so many issues I see with this photo, and see if you can see what I see. So the first thing I saw was this awful neck posture. I mean, if this is a bad post-TNT rectal cancer, lower anterior section, or pelvic exoneration, like being like this for several hours is gonna really do damage to your neck. And then the surgeon is leaning forward too much because the chair is really far away from the feet. So he should really tuck in a little bit more. And then the chair is really not supportive at all. You should have an ergonomic chair, and I don't think his seat is big enough to accommodate his butt, actually. And then his arm is kind of further away out from center. You should really clutch it back into your neutral position. And then last of all, the poor assistant only has a monitor kind of behind her, so she has to turn like 120 degrees for her head and neck to be able to assist appropriately. And in the forward head position, just moving about 2.5 centimeters or an inch forward adds about 5 kilograms of force to your neck. And shoulder elevation increases trapezius strain by 50 to 70%. And pelvic asymmetry can lead to chronic low back pain. If you wear scrubs like I do in the hospital, there's only one back pocket. It's always on the right side. Don't put stuff in your pocket when you're sitting down and doing the robot. You're gonna get lower back pain eventually. And so for robotic surgery, the first thing you want to do is adjust the seat height to match your popliteal height. Move the chair in as far as you can to as close to the armrest as possible. Sit up straight, adjust the console to fit you in a neutral position with your head, neck, and back in alignment. And then bring the clutches back to the center. Always be clutching, always be clutching. That's what I always kind of tell my trainees all the time. Always clutch back to neutral. And then avoid pushing your forehead into the headrest. First, it's very dirty. Everyone's been leaning their forehead on there. And then two is that then you realize you're pushing against your neck a lot. And I know it's really difficult on the XI because the viewfinder is angled downward, and you have to keep your head in there in order to activate. So what I do is I gently touch and look down is what I do. And in endoscopy, keep the monitor level, again, it's very similar, at a little lower than eye height, appropriate table height. Keep a neutral position with your feet hip width apart. Use a cushioned mat. And for those with smaller hands, I do what I call like a 1.5-handed use. So I bring the control head with the wheels down to my other scoping hand and kind of manipulate the wheels with 2 hands while keeping it down here. So I'm not kind of struggling to get it. And then I use my last 3 fingers to manipulate the scope as needed. And intraoperatively, as colorectal surgeons, we do a lot of intraoperative endoscopy, and that is not very ergonomic sometimes. And so if you can, scope in the left lateral decubitus before you start the procedure in position. That's the most ergonomic position, but if you have any chance of needing the endoscope intraoperatively, put the patient in lithotomy. That way you don't have to frog leg the patient and kind of have to get under the drapes and do it very awkwardly. And when you're in a lithotomy, I like to bring the tower in over to my left side if possible, because I'm right-handed, and then drape the connecting cord, or the umbilical cord, as some people call it, over the leg and drop the leg, because once you get into access to the anus, then you don't really need the legs up anymore. And then if you have the robotic tower in the room, utilize a Tile Pro if you have it, because then you can connect the scope monitor to the robot tower, and you can see this nice picture-in-picture and use all the monitors around you in the room. In terms of anorectal procedures, try to avoid using a headlight if you can, but if you need one, use a lightweight one, not one with a battery pack on the headpiece, because the more weight you add to your head, the more pounds of force your neck sees. And use the prone jackknife position. That's a preferred ergonomic position versus lithotomy, but if you have to use lithotomy, which I sometimes have to, lower the sitting stool as far down as possible, or raise the table so it's a little bit more at eye level when they're in steep Trendelenburg. And in the office, I've since transitioned to digital rigid sigmoidoscope. This is a Lumini that we are trialing right now. One for monitoring watch and wait patients and documenting, but also because it's more ergonomic. You don't have to bend over, look through the traditional rigid sig, and that's very helpful. So ergonomic interventions can start small. So just pay attention to your posture. Notice if you're leaning over to one side or not, and shift around and stand feet hip width apart. So I don't know what you wear in the hospital, but I wear sneakers. And if you've ever noticed or logged your miles, you walk like 4 to 5 miles in the hospital alone on average. Well, I do anyway. And so like that's a lot of wear on your shoes, and we really should be changing our shoes every 3 months because that support degrades over time. Compression socks are like a standard. I wear them every single day. I notice a difference if I don't wear them. Utilize floor mats if you can. Use supportive furniture like for the robot, use an ergonomic chair. And use the powered staplers as we discussed. And also targeted stretching micro breaks can help a lot. And so as part of the 2023 recommendations from the American College of Surgeons, they recommend doing micro breaks every 30 to 60 minutes in the operating room. And frequently use neck exercises targeting the trapezius, sternocleidomastoid, and levator scapulae, which are the most frequently shortened muscles in the forward head posture, which is how we're operating. And you can do this regularly. I do it all the time. The residents see me doing it all the time during the case. I did it on the plane ride here last night, sitting there for 16 hours. So it's very helpful. And you can do this too right now in your seats. So you want to practice your deep cervical flexors. So extend upward, down for flexion, rotate left and right. And you should be holding these for 10 seconds at a time. You can also do this deep cervical flexor training, so you nod your head like you're saying yes, up and down, and push down on your chin onto your closed fist for 10 times, and you can feel the flex right here in the neck and a little bit of your pec. And then you can do these standing scapular retractions that help really open up your trapezius and bring down your shoulders. And this one you can do right now. If you want to sit on your left hand, you can bring your head over with your other arm, and then that really kind of, you feel the tug right on your neck here. And then if you want to bring it down and look into the armpit, you can feel the stretch change to your levator scapulae, and that really helps a lot. And then we can do some finger exercises.
To stretch the wrist flexor muscles, hold the arm slightly lower than the shoulder with palm facing down. Extend the hand back toward you, as though looking at your cuticles. The opposite hand may assist by gently pulling back at the hand. The continuation of the stretch is to turn the palm up. As you assist in pulling back the hand, imagine that you're pressing the heel of the hand forward. To stretch into the wrist extensor muscles, you'll hold the arm in front with the palm facing down. Flex the hand back at the wrist. As you assist with the opposite hand, be sure that you're pulling at the hand rather than the fingers. To intensify the stretch, you may curl the fingers into a fist and continue with the same method of gentle assistance. To stretch the deep wrist pronator muscles, it's necessary to lock the elbow into the body to prevent movement in the upper arm and shoulder. Once the elbow is locked in, turn the palm up into a supinated position. You may assist this action by gently gripping with the opposite hand. Stretch into the deep supinator muscles by keeping the elbow locked into the same position, then simply turn in the opposite direction. Again, give yourself a gentle assist with the opposite hand.
I don't know about you, but
To stretch the thumb extensor, we simply oppose the thumb toward the small finger. You may intensify this by curling the fingers around the thumb into a fist, and continue with a downward movement of the hand, giving a gentle assist.
Yeah, this one's tougher. You can really feel that strain. We don't often stretch these muscles at all. So these are just samples of very, very quick little things you can do just to help stretch out muscles that you don't normally stretch out. And the Mayo Clinic with ASGE did a pilot study looking at targeted stretching micro breaks. They did 1 minute break every 20 to 40 minutes, and they found that it does not prolong operative time. And in fact, it demonstrated significant benefits, such as 57% increased physical performance, 38% improved mental focus when they got back from the break, and 87% of surgeons wanted to incorporate this into their daily practice, and 100% reported reduction in pain and discomfort throughout this pilot study. And they found that it also decreased intraoperative errors. And this is a QR code for their website where they show a lot of, it's a free PDF guide, web-based app demonstrating sterile, compatible stretches that you can do. And there's improved ergonomics. So the Da Vinci 5, if you've had the fortune of using it, it's much more ergonomic than the XI. Firstly, the armrest can accommodate a much larger range of body size and types. And then the viewfinder can actually allow you to sit up straight in line with a neutral neck position and operate looking straight forward. And then there's also augmented laparoscopic robots. This is a Maestro from Wound Surgical. I call it the laparoscopic iron intern, where it can hold your instruments, your retraction instruments, so you don't have assistant reaching over the whole time, banging into each other's arms. That's always kind of challenging in laparoscopic surgery. And then it also has an integrated AI feature, so it follows your working hands. It can recognize your instruments, which is pretty nice. And then there was one study where they looked at implementing a core program, a comprehensive OR ergonomics program with the occupational therapist. And they did actual ergonomics education for surgeons and trainees. They looked at real-time posture assessments. Someone was in the room watching the person, individualized feedback and coaching, and an occupational therapy consultation. They found a significant reduction in the RULA scores, improved posture, less pain, better OR setup, and skills that transfer to everyday life. And they recommended that you integrate this in residency and fellowship curriculum. So at Mount Sinai, I give the ergonomics talk every year for the residents, and then I also, like paparazzi, take pictures of the residents while they're operating and then send it to them to show how poor their posture is, especially when they're like suturing skin. That's a very easy one just to, as you on Scrub, as the attending, take a picture of them and see how they do it. Video-based teaching tools, peer observation, and feedback. And so in conclusion, our greatest asset is ourselves. A surgical career is a marathon. So optimize OR setups, maintain neutral posture, just pay attention to it, and implement micro breaks. Like in colorectal surgery, like we have natural cadences of our surgery. So let's say after your dissection, take a little break. You can go back to resecting, and then before you do the anastomosis, there's like natural breaks every like 45 to 60 minutes in our cases, and so these are perfect times to do these little micro breaks. Advocate for equipment for you. Ask your institutions, ask industry to help develop more ergonomic tech, and seek training and address your symptoms early. I know so many surgeons who've had various surgeries for like back, neck, issues, and you don't want to get to that point. And personally, I believe disability insurance is a must for every surgeon. This is our livelihood, and if you can't work, that's how we survive. So, thank you for your time and your attention.
Thank you again, everybody. Let's skip and that's good. Here is the healthcare sector's paradox. Healthcare is an ever-growing industry meant to save lives, but it is also an unintentional contributor of carbon emission, responsible for 5% in globally. So this is a operating room. This is where the most of it happens. This is my operation picture. In this photograph, I am engaged in laparoscopic surgery, which shows the prevalent use of single-use surgical instrument and the significant reliance on disposable items. And this is where the carbon comes from, we use every time. And considering robotic surgery, it has many advantages over traditional laparoscopic surgeries, but as you can see, there are drawbacks such as the use of large amount of disposable plastics. If you look at this systematic review in British Journal, you can understand the difference in greenhouse gas between laparoscopic and robotic surgery. Robotic surgery usually produces a 44% higher greenhouse gas emission than laparoscopic surgery. This is the reason. Let's move on to green surgery. Green surgery is the title of a landmark 2023 report endorsed by UK surgical colleagues. This message is clear, simple and clear. First, prevent unnecessary surgery. Second, when we operate, use less, and reuse or recycle whatever we can. We can start with anesthesia. The desflurane produces 10 times the emission of isoprene or sevoflurane. And this is 5 hours rule. Royal College of Surgery published the checklist, and you can download online. And here is the detailed items. This is my proposal. I would like to preoperative, operative, post-operative, and engagement like this community research and education. This is our research currently undertaking. Let me show the published paper in surgical endoscope. This is survey data from our colorectal surgeon, and this is a life cycle carbon footprint of laparoscopic and robotic assisted area. This is unpublished data, and data show that here is the key result: laparoscopic LAL 160 kilograms CO2 equivalent, and robotic assisted is more than 64 kilograms per cases. So this waterfall chart tell the whole story. This is product and electrical use, anesthetic gas, CO2, and waste disposal is the make the difference. This is summary, and the second study. How we can reduce the footprint? Can we lower the CO2 pressure? So we undertake this retrospective study with LCL. This is a prospective cohort from ERAS registry from our institute. 143 patients undergoing minimally invasive colorectal surgery. The red line is the low pressure group with 8 millimeter mercury with LCL system, and the standard pressure is 12 millimeter. And the data shows the low pressure group showed early recovery, EQ5D QoL index, and even after adjustment, low pressure remain independent predictor of better QoL recovery. So this is summary. This is a take-all message. First, surgical disposables. It's time to revisit reusable alternatives, and MIS, rational use of robotics. And third, material innovation is needed. And finally, conventional pressure can be lowered by low pressure surgery. Thank you for your kind attention.
Thank you very much for the kind invitation and introduction. I would like to sincerely thank the Society for the privilege of the podium, and extend that to the entire Korean people for their hospitality and welcoming us into this lovely country. This is my first time here, and I could assure you it won't be my last. These are my disclosures. If you are a football fan, unfortunately, I'm an Arsenal supporter, so Tottenham, I'm sorry about it. And I don't have any secrets on my slides, so you could take photos or whatever you like. Now, surgery is one of the most dynamic sciences, and from the days of basic surgical procedures and instrument to today when we do robotic surgeries and AI augmented realities and all these lovely technologies that we have put us actually at the forefront of every scientific society and every scientific adventure, because surgery is always moving forward. I tell my residents and my fellows that I'm teaching you the technology of yesterday. People will hire you based on the technology of next month, and you will be practicing the technology of next year. And when you are as old as I am, you will be teaching a technology that's not even invented. And I'm a prime example. When I was in medical school, nobody thought of robotic surgery. And now every day I teach robotic surgery. So be prepared for the ride. What I will try to do in this presentation is actually to summarize what's going on and how we're going to approach it from now on, and make it easy and enjoyable, because when you go to the operating room, you actually want to enjoy your time. And the first thing I tell people, learn how to tame the beast, which is the technology. Understand what it looks like, how it's functioning, and how to avoid mishaps, and learn how to move forward if problem happens. We're going to talk about the future OR, how it's going to look. We touch base on some training, tips and tricks, and what happens afterwards. When you finish training, you actually just start training. There is no day that comes and goes without us learning something new. So it's a continuous process, learning, training, and relearning and retraining. And one day you are in the operating room as a learner, next day you are a teacher, and the third day you are a learner again, learning something new. When we talk about the operating room, there are 4 major issues we need to address: the technology, the safety, the team, and as I said, the continuing training. Every day we're facing a new technological advances. Sometimes it's an old technology, but it's a new technique. Sometimes it's an old technique, but it's a new technology, and then we have to adapt. And I think, although we are colorectal surgeons, and I'm a colorectal surgeon, and the introduction of technology didn't change our practice much, but imagine when we were doing opening surgery, we were doing lateral to medial approach, and then minimal invasive came, and we started doing medial to lateral. And we do top down and bottom up, and all these things that we didn't do before using either an old technique or a new technology. We added another complexity, which is the AI. It's a beautiful tool. It's help in dynamics, decision-making, coordinating, but it also adds another layer of complexity. What layer of complexity we have? Our decision is being challenged, our training is being challenged, and also the way things are moving forward. With that also comes a problem of safety and efficiency. We need to be safe as surgeon, and we need the device and the machine and the technology to be safe, to be practicing. And then during the talk later on, we'll talk about cybersecurity and all these things. Now, teams are very important. In the past, you do one, teach one, and you are the boss of your own operating room. Today, we have multiple teams in the room, and we have to incorporate all these teams into the new technology. Surgeons, we have our new tools, but also anesthesia have their new ventilators, they have new medications, they have a new measuring device, they interact differently, they have to teach, and they have to train. And you have a nursing team also in the room. They need to learn, they need to train, they need to interact with you. One of the things I've done in the past is take the entire team, and we'll talk about it later, and go and learn the new technology as a team. Don't send yourself or your surgeon only. You have to take the nurse with you, because when you are operating, doing a very difficult perforated diverticular disease on a BMI of 50 at 2 o'clock in the morning, and your scrub tech and your scrub nurse is always work with orthopedic, you will never get the stapler right. If you don't know how to do it, you're going to get frustrated, you're going to get angry, and you're going to get an environment that is not good enough for safety, efficiency, and patient care. So please learn, teach the team, take them with you in this journey. Now, when we talk about the newcomers, as we talked, we have 4 different identities. We have our medical students, residents, and fellows, and those people have fantastic knowledge. They know the book, like some of my students know Substance and Valiant Love and all those books from skin to skin, but they lack the experience. They lack the social intelligence. They lack the emotional intelligence to operate in the room. So those people, despite the knowledge, they cannot translate this knowledge into an operating decision-making or operating movement despite the new technology. What we need to teach them is how to translate all of that into something they could actually do it in practical life. And we'll talk about how we're going to teach them how to do this. Now, you have your nurses. My scrub tech has 20 years of colorectal experience. So when I operate on the day, I'm a very happy man. At night, it's a completely different. On a weekend, it's a completely different environment. And those people also need training. So give them time to learn and participate in their training of these new technologies. They need to assemble the robot for you. They need to assemble the stapler. They need to actually use the computer. And now sometime when we do the augmented reality and we download the pelvis into the computer, they need to learn all of these things. Thirdly, we have a new group of people now coming to the operating room. Those are very senior people. And I'll give you a simple example. I worked with one of my residents who actually was a practicing surgeon in a country, then moved to Canada, did 3 years of research on technologies, and then became a resident. Now this guy has the experience of the surgeons from his own country. They have the experience of the technology because they did a 3 years degree, a master's degree, on how to implement the technology into the operating room. And now he's residents. How you're going to control those people is very, very important, and how you're going to integrate their experience to use them as an asset rather than something bad. So these are very important people. And now we have to adopt to the onboarding pathways. And every single hospitals now, every training program will have some sort of, like we have for our residents, they go monthly for a full day of educations and training. They use simulators, they do team interactions and all of these things, so they will be ready on top of their weekly educational lectures. So how the future operating room is going to look and what skill we need. Those skills actually will be in kind of 4 major categories. You have technical skills, you have non-technical skills or the human factor, you have integrating training, which has to be a continuum process, and also you're going to measure your outcome and how the outcome will affect your training skills and adopting the new technology. So these are very important 4 categories that we need to actually make sure they interact efficiently. They are not separated from each other. So you're going to jump from the technical skill in the same operating case, from the technical skill to the non-technical skills, and then you go back to technical skill, and then you're going to jump into utilizing this case as a training case. So I'll give you an example from my work. We will divide the operation into 2 or 3 steps, one then for the junior residents, one for senior residents, one for the fellow, and the demands are different. So when I'm doing a right colectomy, for example, I say to the senior residents, you're going to do the medial dissection, take the vessels, find the duodenum, and then for the juniors to use the energy device, or if we are on the robot, use the robot to take the lateral attachment, and then for the fellows is to do the intracorporeal anastomosis. So these are the steps. Every one of them will be learning, and then move forward and backward between those cases and intervene as you need to do. And at the same time, when they are operating, they will become the team leader regardless of their position in the training. So you could actually teach them and assess their interpersonal skill and how they're going to interact with the nurse, with the anesthesia, recognizing there's a problem, and raise awareness at the same time. And at the end of the case, we will say, okay, so what did we do, how we learned, how we can improve, and the better you could do the step, you will be graduated to the next step and so forth. And at the end, you will be in a position to do A, the entire case, and B, supervising the other people to do the case, and then the circle will start again. We talked about how we're going to integrate those, and we need a safe environment, and simulation and simulators are the best place to do it outside the operating room in a safe environment, and it has to be precise as if it is the operating room. And that is important because you need to simulate the environment, not only the case. It's It's a zero patient risk environment, and run team scenarios. I was doing my PhD way back at Imperial College, and at that time in the late 90s, early 2000s, we used to do simulation for teamwork. You're operating, the phone rings, they call you from the emergency room about another case, and you have to do this, then the bleeding happens, and they measure your interactions and teach all those people how to interact within the team, and they know exactly their position in the team. That's very, very, very important. And then learn what you learn and take it to the operating room. The simulating devices now and the simulating environments are beyond recognitions. They are really, really good. They give you instant feedback. They could correct you when you are wrong. And it's fantastic. So I really do encourage you to take your trainee into those simulated environment and let them practice and practice and practice and practice. And we published a study back a couple of years ago about intracorporeal laparoscopic when we did a simulated environment and took every single junior residents to do that, the continuous intracorporeal anastomosis for bowel anastomosis in the simulated environment. And 100% of them did their first case exactly how it should be done. We didn't need to worry about that transition. So please utilize it. It's available to you, and it's quite important. Now, when we say about building digital confidence, what does that mean? We need to be digitally educated. We are all, at some stage, are digitally illiterate. We need to learn the language of the machine that we are talking to, the interfacing. It's all video-assisted surgery, and we're adding AI into it, and we added augmented reality, and we're adding virtual realities, and decision-makings, and you need to understand every beep, every pulse that comes from that machine, and how they interact with each other and how they interact with you. The cybersecurity is huge, and Dr. Hahn talked about how important the DV5, for example. It took us almost 2 years in Providence system to get the DV5 into our system, is because we have issues with cybersecurity. They store whatever case you do, it goes into a central storage, and you lose the control over it. So that's a very important thing. So when we're going to introduce new technologies and we're going to introduce new devices, we need to make sure that we are HIPAA compliant and patient's confidentiality and surgeon confidentialities. It's very important. You're probably aware of the black box in the operating room, and it's now in most of the rooms. It records everything. I was privileged to know Theodore when he was a research fellow too, and how that whole business started and where it is now. One of the issues in the beginning was how I'm going to react as a surgeon in my operating room. Am I allowed to talk? Am I allowed to joke? Am I allowed to, take a step backward and do the stretches that we've been told to do now? So these are quite important. It's a two-way system. It's always important to understand that. And stay ready when the technology fails. And this is a prime example. My colleagues previously wanted to give a talk, and it didn't work. And we have to be ready to kind of jump in and learn when the grasper of the robot leach into the tissue, the rectum, which is only 2 centimeters above the anal verge, and it doesn't allow it. You need to know how to dismantle that and then convert to open. It's fantastic that we are doing, laparoscopic appendectomies and cholecystectomies now as a standard, and many of us will never participate in open cholecystectomy probably, and the last one I did is almost 20 years ago. But we need to learn those things. So keep it part of your simulation environment. And when there is a chance, when something goes wrong and you have to say convert to open, don't get frustrated. Using it as a teaching environment to the team and say, that's what happened, and this is how we're gonna deal with it. Step 1, be calm. Step 2, get the instrument. Step 3, deal with the problem, and so forth. And make it a stepwise and engulf everybody in that environment, and don't get frustrated about it. And, we all use electronic records, and sometimes the computers doesn't work. We recently, about a few months ago, some system got hacked, and we couldn't use the computer. So we have to go back to ordering, bloods and put all our orders on the piece of paper. And many of our residents didn't know what the pen do. So that's a problem. We need to educate them that pen is a very important tool, and a piece of paper is also an important tool. So take that example and take it with you into the operating room. So when things go bad, you could actually save yourself. There are some ethical issues that came, particularly now we're doing AI and virtual realities and decision making, and most of the algorithm now, it's all generated. Even when you go to the American College and you put your Apache score and you want to know what's the likelihood of a patient surviving an operation, this is a tool that gives you a decision. So you need to think of your patient safety first. You need to think of automation. Part of our recent work now with Intuitive is automated independent knot tying. It's there. It's going to come soon, hopefully. So you don't even need to tie a knot. You just press a button, and the robot will do that to you. So these are all issues that we have to think of, whether they are ethical, whether they are none, and the decision making, because the computer will make the decision based on what they know. There are no emotions here, so be careful of that. And also the human factor. We are the master of those technologies, and we are the masters of those devices. If we don't keep calm, if we are not in charge of them, they could actually harm the patients. And also, if you're going to introduce anything new, make sure that your patient is aware and your hospital is aware, and get the patient consent for that. All of that is wonderful. You've got everything on board. What do you need? How are you going to assess? And how are you going to develop further technology? And that starts with adaptability and lifelong learning. So we have to install in ourselves and our trainee that learning is a continuous process. We cannot stop learning, and we have to adapt to any new technology. Our training system has changed. In the past, as I said, see one, do one, teach one. That's all gone. And you cannot now depend on a longitudinal way of training when you just do the case day in, day out, and learn. That's impossible. The training period became shorter. The complexity of the training became severe. And we have new things we need to teach the residents. So when you learn, you have to actually compartment those things and then interact with them and say, on this case, we're going to learn 1, 2, 3 today. And in the next case, we're going to use 1, 2, 3 to learn 4, 5, and 6 steps and what have you, and move back and forward. Always do it. Sport is a prime example. They do it religiously. They do their stretches, they do their on-field, they do technical, and the coaches sit one-on-one with their players and teach them what they need to do and where to go, and then do it again as a team, and redo it, and redo it, and redo it, and redo it. So that's quite important. Allow your people to have a voice. They need to feel free to say no, to raise concern, and tell you how they feel in a clear, safe environment, and it's a mutual respect. So people will say, I cannot keep up with what you're teaching me. because it's too much for me. And you will see that when you go and train, you will see one of your residents will pick every single thing within a day or two, and the next residents, they will need a month, and so forth. So let them express themselves, let them interact with you in a better way, and again, make sure that you sustain the growth and the support. What does that mean? Learning again and again and again, and introduce the new technology, and learn and build your team to adapt and accept the next level of whatever technology is coming. So what are our takeaway messages? Recognize that the operating room is a complex environment. It's really, really dangerous, complex, but make it fun. It's enjoyable. It's one of the most enjoyable places probably for a surgeon. So let's make that experience enjoyable too. When you teach, every learner needs to learn at their own speed. That doesn't mean you have a person who will need 10 years to learn and you accept that. This is failure. That's not teaching. You have a 5-year residency program, and you have a 2-year fellowship program, and the person needs to progress according to a set timetable. But how they're going to progress within those sections, that's up to you and them to interact and make it easy. Don't be shy from using simulations, and educate your learner about technology. Tame the beast. You're going to learn this quite a lot from me. You have to learn how to be the master of the technology before actually you could practice and then teach the technology. And, there are generations, probably among us in this room, when we were in our training and some new technology came in. I remember in the late 90s, early 2000s, when laparoscopic colorectal surgery became the norm in England. As a resident, I was better than my boss in a certain hospital because they've never done it and they are learning. But I came with 2 or 3 years experience learning with a minimally invasive trained surgeon. So these are quite important to kind of adjust to those. So don't be shy in using all those technologies. And again, the human factor is important, and install in every newcomer that learning is a lifelong experience. You will never stop learning. What you started your training, it will never be the same when you finish your life as a practicing surgeon. These are quite important, and if you could keep that in them, you actually not only taught them to be surgeons, but you taught them to be a lifelong learner. Thank you very much again for the opportunities and the privilege of the podium.
Thank you, Chairman, for kind introduction. I'm Sunjin Park from Kyung University, Korea. Today my topic is equity in colorectal MIS, lessons from HERA and nationwide registry in Korea. I have no disclosure. Today my presentation has 2 points. First is current MIS status for colorectal cancer in Korea based on HERA nationwide data. And second is that I'm going to introduce ongoing project KSERS and share the interim progress result. Our team conducted 3 studies using the HERA nationwide database, and they are about the penetration rate of minimally invasive surgery for colorectal cancer in Korea. This was the first study published in JMIS, the official journal of this KSERS, which included the data from 2008 to 2013, obtained from HERA database. As you know, we are in Korea, health insurance covers the entire population. So HERA database is a representative source of national data in Korea. So in this study, MIS rate for colorectal cancer in Korea was 43% in 28 and steadily increased to 65% in 2013. You can see the robotic surgery rate here. And it was highest in 2013, but just less than 5% of total MIS. This is a second study, which includes the data from 2013 to 2018. Not only national health insurance, but also medical aid patient and veterans patient were included. However, this second study missed the robotic surgery data. Anyway, conclusively, we reported the overall laparoscopic resection rate for colorectal cancer was 78% in 2018. This is a third study, including from 2019 to 2023, published in JMIS last year. For 5 years, over 71% patients underwent laparoscopic surgery and 11% underwent robotic surgery in Korea. It is observed that open surgeries gradually decreased, laparoscopic surgeries remained stable or slightly increased, and robotic surgery gradually increased. And when tumor location was categorized as left colon and right colon or rectum, the proportion of open surgery was highest in the right colon, and 21%, the lowest in the rectum, 12%. In contrast, the proportion of robotic surgery was highest in the rectum, 25%, and lowest in the right colon, 4%. You can see the hospital stay according to the medical insurance type and surgical approach in Korea. In general, NHI patients, the mean length of stay were 15 days for open surgery, 12 days for laparoscopic surgery, and 11 days for robotic surgery. And these were significantly shorter than those of a medical aid patient for all surgical approaches. Such differences were similarly maintained in veterans patient, but the number was quite small, so direct comparison is difficult. You can see the data according to hospital size, which is classified as tertiary general hospital and general hospital, hospital and clinic according to HERA definition. Hospitals have 30 to 100 beds and clinics have less than 30 beds. Among total cases, 67% were performed in tertiary general hospitals and 30% in general hospitals in Korea. In tertiary general hospitals, open surgery rate gradually decreased from 62% to 54%. In contrast, laparoscopic and robotic surgeries remained stable at a similar rate in tertiary and general hospitals. Interestingly, in hospitals with 30 to 100 beds, a total of 22,217 colorectal surgeries were done for 5 years. Its proportion was quite small, just 2%. But however, the average rate of laparoscopic surgery was more than 92%. According to the hospital location, 43% were performed in Seoul and 18% in Gyeonggi and 6% in Daegu and 6% in Busan. And over 65% concentrated in the metropolitan area, such as Seoul, Gyeonggi, and Incheon. And the other 80% in regional 5 metropolitan cities, such as Busan, Daegu, Gwangju, Daejeon, and Ulsan. This is summary of a nationwide study using HERA database, and the rate MIS for colorectal cancer in Korea has continued to increase, reaching 84% in 2023. The rate of laparoscopic surgery exceeded 70% and has recently plateaued. The rate of robotic surgery has continued to increase, particularly in rectal cancer, exceeded 28% in 2023. In Korea, 67% of colorectal surgery were performed in tertiary general hospitals, whereas 30% were performed in general hospitals. And the others is the same, and I moved to, and conclusively, unfortunately, HIRA data does not include tumor stage and oncological outcomes and complications, which limit further research, and I think this should be improved in the future. Secondly, I'm going to introduce ongoing this KSERS project briefly. As you see the previous slide, recently we have been achieving high penetration rate of minimal invasive surgery. We have to improve not only surgical outcomes, but also surgical quality. And we need quality assessment, surgical standardization, and big data platform, and complication prediction tools. And these systems require national effort and insurance funding under the government support. In order to improve surgical qualities, United States began a program in 1985 at the Veterans Affairs hospitals, and they expanded it to include numerous hospitals nationwide, leading to currently ACS, NSQIP. Japan benchmarking and US program established the NCD program in 25, involving 10 surgical societies. NCD currently covers over 100 surgical procedures, and Korea is a little bit late, but actually the Korean Society of Hepatobiliary and Pancreatic Surgery used to initiate a program 10 years ago, and a single procedure, cholecystectomy, but it failed to expand into a national program. So in 2023, Korean Surgical Quality Improvement Project was launched, and for major 5 abdominal surgeries funded by government. Based on this past experience, a new Korean project was launched, and to build a national surgical quality improvement program. This project includes core tasks such as predicting complications, providing feedback to individual institutions, and establish guidelines. This nationwide project is led by the Korean Surgical Society and financially supported by the government. It covers 5 major abdominal surgeries. The Korean Surgical Research Foundation serves as the head organizer, and the 5 major abdominal surgeries include stomach and colorectal, liver, pancreas, and kidney. Each of 5 major surgeries is served by different institutions. I'm a colorectal surgeon, belong to the 3rd part and colorectal surgery, and here the chairman, Professor Junwon, is my boss, and the PI of the 3rd part. And this is a time schedule of this project, and it has a 6-year duration, divided into 2 phases, the former 3 years and latter 3 years. And the first 3 years was from 2023 to 2025, and the primary focus was to collect retrospective data more than 200,000 cases. Last year, we successfully completed the phase 1, and from this year, we have already started the second 3 years. During the next 3 years, we plan to collect nationwide the data prospectively and build an AI system to predict complications. I briefly introduce the project outcomes of phase 1, and like American NSQIP or Japanese NCD, we make unique name, KSERS, Korean Quality Improvement Platform in Surgery. We have designed and registered the general and individual trademark for 5 major subparts. We developed electronic system on the web for case recording and published data input manual. The website is linked to the official website of the KSS, and it has been developed for not only electrical case record, but also training of research nurses. For the last 3 years, we successfully collected retrospective data on about 252,000 cases, which is 111% of the initial target case number. Given the data quality management, it is primarily working on the web real time during data entry and prompting user with queries and disabling items. And also data management committee was established and visited the institution to conduct data inspections audit. As a result, data consistency rate was very high, exceeding 99%. If there is any discrepancies, it was reported and feedback is provided to relevant institutions. I will introduce the FAST project for the next 3 years. US NSQIP shows that participating institutions experienced a significant decrease in complication rate like this before NSQIP and after NSQIP. We plan to provide feedback report to participating institutions to encourage them to improve surgical quality. The result of institution will not be publicly available, so their own ranking or performance will be disclosed to only the participating hospitals. An AI-based risk prediction system is likely operate like ACS NSQIP system based on the patient characteristics entered before surgery. This AI system will predict the length of stay and complications and mortality rate. We plan to build our own system based on Korean national data. Across all of Korea, more than 80 hospitals, including tertiary and secondary hospitals, are participating in this project. This is the last slide, summary. For the next 3 years, our key achievement will be to prospectively collect and analyze data and develop AI-based complication prediction system. We will provide clinical pathways and clinical decision supporting system and web-based feedback system for participating institutions and doctors. And also we'll develop guidelines for various surgical approaches and procedures. I hope this project will be a great success so we can have our own database. Thank you for kind attention.